very important innovative session, Magic of SICS. So I request Chairperson Dr. Boramani sir and Vignesh Raja to come to the dais. I request Co-Chairperson Dr. Parishik Gopte, Co-Governor Dr. Deepak Mishra, please come to the dais.
Hi, Dr. Raja.
Moderator Dr. Purvi Bhagat. I request all the discussion to take the front seats. Dr. Purendra Bhasin sir, Dr. Rajvinder Kaur, Dr. Sujata, and Dr. Jennifer ma'am. So welcome to ISM SICS. First we'll start the session with the milestones and the journey of ISM SICS. I request audiovisual to start the journey. Sound, please.
The video sound. Good afternoon. This is a session by ISM SICS.
Scleral tunnel incision is a secure incision. There are newer advances in MSICS, like 2 mm SICS surgery, smart incision surgery, and customized incision cataract surgery. The International Society of Manual Small Incision Cataract Surgeons was launched in 2005 by Dr. Amulya Sahu, the founder chairman, and by Dr. Jagannath Boramani, the present executive chairman. Immediately after the formation, ISM SICS started organizing many international events. ISM SICS was invited to conduct a wet lab in APACRS in 2015. In 2018, in WOC, ISM SICS conducted a session and a wet lab. The Master's Guideline ebook was launched during this conference. In 2022, the ESO invited ISM SICS to conduct a 2-day workshop in Dubai. In the same year, the organization conducted a session in Rensko. In 2023, the annual conference of Emirates Society of Ophthalmology, ESO 2023, ISM SICS was given a session, a workshop, and a wet lab. In the same year, ISM SICS conducted a session and performed live surgery in Moscow. In ESO 2024 again, ISM SICS conducted a session, a workshop, and a wet lab. APAO 2024 offered 2 wet labs to ISM SICS. In November 2024, ISM SICS was invited to conduct a 5-hour symposium and wet lab by the European Society of International Ophthalmology. In India, ISM SICS has regularly been invited to various CPD programs, state conferences, and to participate in AIOC, the largest conference in India. ISM SICS started holding world conferences every 2 years, from 2015 onwards. CCC, stands for Comprehensive Cataract Conference. Our past partners for these conferences were Aravind Eye Care System, Disha Eye Institutes, PGI Chandigarh, and LV Prasad Eye Institute. From 2024 onward, AIOS2025-GP141-Magic started conducting zonal conferences. The West Zone CCC was held in Mumbai. The East Zone CCC was held in Shillong. And the South Zone CCC was held in Chennai. In 2017, AIOS2025-GP141-Magic became a partner of Help Me See for training on simulator. AIOS2025-GP141-Magic has chapters in almost all states of India and in 24 countries across the globe. These are few images of online, as well as physical launching of chapters in various countries. AIOS2025-GP141-Magic has conducted more than 80 online webinars. The organization has a women's wing also. The online Global SICS training program was inaugurated in 2022. Though AIOS2025-GP141-Magic had published many journals in the past, from 2021 onwards, it started regularly publishing the peer-reviewed journal, which has been now indexed with Embase and Mcare. This is our website. Scan this QR code to become a life member.
So that was the magnificent journey of AIOS2025-GP141-Magic, what we witnessed just now. Now we'll start with our scientific session. There is a slight shuffling of the speakers because Dr. Chinmay Sahu, he has to leave. So I invite him to speak on a very important topic, that is converting from FACO to SICS. Dr. Chinmay.
At the outset, I would like to thank AIOS2025-GP141-Magic for this opportunity to present today. I must admit that, can I just give you 2 minutes before we start playing? So I'm primarily someone who's doing phacoemulsification in my practice, and realized quite early in practice that learning SICS is as essential to doing a good job as phacoemulsification is. I've trained in MS from Nair Hospital, Mumbai, and we were kind of shifted from ECC to phaco quite quickly. So we had a very small, short phase in which we learned SICS, but wasn't adequate enough. So this presentation, I'm trying to highlight through 2 cases. One is a case where we come across very brown cataracts, and when you're trying to do a phacoemulsification in such cataracts, depending on the machine that you're using, the energy that can be used can be quite high and land up damaging the corneal endothelium and the wound, and at times can even put pressure on the zonules and lead to, nucleus drops and PC rents. And the second case is where, again, you can get trapped while doing a phacoemulsification with rhexis issues, and how SICS can actually bail you out. The quality of videos actually may not be rightly, up to the mark. These are quite early in practice, but put up here to highlight these situations. So I'll start with this. Can we play the video, please, now? This is the first situation when we are dealing with a brown cataract. Well, I must admit that I'm not very comfortable with nucleus cracking in the anterior chamber. So I plan a large incision, which is roughly 1.5 millimeter from the limbus. a straight incision with scleral pockets. So here a phaco is planned, but I have created the scleral tunnel and the pockets. Now what I'm shown is in this particular brown cataract, because phacoemulsification is my comfort zone, I am trying my best to see if I can go through with the phaco. The scleral tunnel is actually helping me in this situation because the wound burn is minimal or not happening because of the design of the tunnel. One challenge when you're doing a scleral tunnel phaco can be a shallowing of the anterior chamber, but if the wound is constructed properly, it really doesn't happen. Now, after having struggled a lot, I decided that I'm going to damage the endothelium and I should convert to the... Now here the rhexis should be large enough, because if you're trapped with a small rhexis, getting the nucleus out can be an issue. Now here I'd already done a bit of trenching, so the central core is missing. So to manipulate it is not that easy, but I find using a 26 number needle helps engage the tip of the pole, and rotating it in an anti-clockwise manner, I managed to manipulate it into the anterior chamber. Now, in my case, I'm using a visco expression and I'm depressing the tunnel using the repositor out here. So the nucleus smoothly comes out of the tunnel without any issue. So in this situation, rather than letting my ego take over and saying that I'll try to complete the case using phacoemulsification, I decided to convert. The second situation is where again, here I hadn't planned a scleral tunnel. I went with a clear corneal, but there was an issue with the rhexis inferiorly. I started seeing a flutter. Somewhere the rhexis, probably while I was doing the phaco, I must have caught the edge and it got cut. So I tried trimming the edge of that rhexis and I started of the flap, and I again tried to see if I can get away doing a phaco. But the cut edge of the capsule was getting into the phaco probe, and there was a high chance that this would lead to a zonular dehiscence and land up with a nucleus drop. Now here what I did was, instead of extending the clear corneal tunnel to an ECC kind of, I have created a scleral tunnel going behind and creating a deeper plane. It's a little controversial that whether this can really work, but I have found that this works quite in 3-4 situations that I've landed up with, where I've created again a scleral incision, created a deeper plane, created the pockets, and you can actually use that scleral tunnel and make an entry into the anterior chamber. Before that, again, we have to manipulate the lens out. It's very important that we do not lead to cause a problem with the capsule and extend it. So visualizing the nucleus edge properly and lifting it out of the bag is quite critical. And now you can see that I'm depressing the scleral tunnel, and the clear corneal tunnel is the way it was, and the nucleus has come out. Now one of the reasons for doing this is that I believe this would lead to lesser astigmatism, rather than extending the clear corneal tunnel at that point and then trying to suture it up. Here also I have had to suture because I wasn't very comfortable with whether this would remain secure, but a couple of interrupted sutures have worked in this particular case. So these are 2 short videos basically to show that SICS is an extremely important part of our armamentarium, and even if we might be doing high volume phaco surgeries, knowing to do a good SICS can bail us out of very tough situations. Thank you for this short talk.
Thank you very much, Dr. Chinmay. One or two question or comment quickly, and the final discussion we'll take at the end of the session. Anyone has a comment?
Actually, the larger the rhexis in an SICS, it works better. And it's counterintuitive when you're doing a phacoemulsification, because you would want the edge of the rhexis to overlap the lens. But what I tend to do is, if I anticipate when a brown cataract, I always err on the side of going larger on the rhexis, because if at any point of time I'm getting stuck, I know that I can try and get it out. Size-wise, I would almost go to the extent of where the pupil is dilated, so that I can manipulate. But once you have that, manipulating the lens once one pole is out and using visco to deepen the anterior chamber, and then it happens quite well after that. In a worst come worst situation, maybe 2 relaxing incisions can work. Again, I tend to do it, if I do it at 10 and 2 o'clock rather than exactly opposite to each other, but because that can lead to an extension of the rhexis. So in situations where I've found that the lens is not coming out of the bag, rather than be more aggressive and try to manipulate and cause a issue, I've given 2 relaxing incisions at around 10 and 2, and it works well in my hands. The lens then tends to come out quite easily out of the bag. Yeah.
So would you do a 8 mm rhexis for a harder cataract like this? Bigger one?
The larger, I would say yes, but because in most of the situations I tend to try to do a phaco. Rarely do I actually honestly go to a SICS in today's practice, but yes, I will kind of go in between. Maybe not directly up to 8 mm, 6 to 7 at present is what I would have done. Yeah.
Yeah.
Correct.
And
It's too large and it's kind of.
And
So
with
the
it-
other thing that happens is in these the chances of the rhexis slipping and it going to the periphery can be quite high. So rather than take that chance, I would rather go. Yes. I would be in my hands when I've tried to do a rhexis. If I can't visualize where I'm kind of doing the edge, I'm scared actually that it might extend that way.
For conversion, you have talked about making a scleral tunnel behind your corneal incision.
Yes.
it is a
So
good
that
way
is a
instead of-
bit controversial. You can counter say they've already made an entry through the
Yeah.
clear
No, it is
corneal
not
tunnel.
controversial. Even if you intersect your corneal tunnel, it doesn't
It
matter.
works. I've seen.
Better
Yeah.
you should remain in that same meridian.
Yeah. In fact, in this case, that is what we did. It eventually ended up, I used the deeper plane, but I made an entry through that corneal. It kind of de-roofs it, but it works well. It seals
works
off
very
quite well.
well.
Yeah. That way.
Do you want the
Correct.
Yeah.
But as I said at the outset, I'm someone because, I have not done too much of SICS, honestly. So I'm not very comfortable doing. Also, this idea of this presentation was to show that though you could be doing high volume phaco surgeries, but knowing SICS is critical. I'm no expert on SICS surgery, but knowing this has helped me bail me out in tough situations.
Yeah. Now we'll just take one more suggestion from Dr. Sujata and then we'll move.
Which is what I showed in the
he
first
has shown
video.
in the first, yeah.
So, yeah, I showed that. The first case which so the first case that I did was because if I have a specular report which shows that the endothelium is, kind of the endothelial cell count is below 1500, then I would do a scleral tunnel phaco only. Correct. Yeah, but my challenge with the scleral tunnel phaco over the years, see, it's whatever you keep doing in volume, you get comfortable. So scleral tunnel, many a times the wound kind of extends a bit, the entry point enlarges. So leakage tends to happen in my hands. No, I'm not saying that that's the case, but I'm just saying that that's been the situation. So I've had to use more and more visco to maintain the anterior chamber. Whereas I'm someone who uses very minimal when I do my phaco surgeries. I absolutely agree with you that it's far safer to do a scleral tunnel phaco and plan it accordingly. Yeah, that's why the first video was for that.
Yeah,
Alright.
that was
Thank
a good
you.
discussion. Thank you, Dr. Chinmay.
Bye.
Now next, we have, as we had seen in the video, the index journal of Global Journal of Cataract Surgery and the Research in Ophthalmology. So I request Dr. Purvi Bhagat to say about the journey of this journal through ISM SICS.
Thank you, Dr. Neeta. Firstly, I would like to thank Dr. Sahu sir, Dr. Poramani sir, and Dr. Nayak sir, not only for making me a part of this journey, but also for allowing me and giving me this opportunity to share this journey with all of you in this prestigious conference. So, this is the journey of the official scientific publication of the International Society of MSICS. The journal's name is Global Journal of Cataract Surgery and Research in Ophthalmology, now fondly called as the GJCSRO. Can you shift the slides? Yeah. So it all began in the end of January 2021 when the then secretary, Dr. Srinivas Joshi, had received a mail from one of the leading publishers asking whether we would be interested in initiating a journal for the society. So he just casually forwarded it to me and one another office bearers. And at the time, we were already working on publishing newsletters for the society on a regular basis. So I thought, like, this is a good opportunity. Let's go more scientific and have a structured journal rather than the newsletter. So we began the discussions with the core office bearers, core committee members of the society, and we all understood it was going to be a very big responsibility, because it was not something to be like you have just a few issues and the journal dies down the years. We wanted to sustain the journal and make it truly international, considering the platform that the International Society of MSICS itself is. Considering the experience of Dr. Nayak sir with the JCOR of MOS and with the IGO for a lot of years, it was decided that he would be the chief editor. And of course, then it was a big blessing in itself, because working with him in parallel and under his guidance was a great boon. So lots of discussions happened with Nayak sir also, and lots of calls, and we understood the challenges, limitations that would be there, ethical issues that revolve around a journal publication. And it was, of course, taken for granted that yes, it's going to be a very big task, a huge responsibility. But then finally all of us decided that yes, okay, let's take the move and have the journal going. So we discussed with publishers, the primary one who had sent us the mail, and with other ones, the costs involved, negotiating with the publishers for different costs, and deciding on the name of the journal. And finally, we settled down on this name, the Global Journal of Cataract Surgery and Research in Ophthalmology, which publishes not only cataract related articles, but any research related to ophthalmology. And the publisher was settled in as the Scientific Scholar, who continues to be our publisher till date. We gradually built up the editorial board. Of course, Dr. Nayak sir as the editor-in-chief, myself as the managing editor. And we had the pleasure of having with us two young, enthusiastic, dynamic associate editors, Dr. Aarti Heda and Dr. Nikunj Tak, who believed in me, believed that we could take this up, work on this, and they continue to work for this journal. And now we also have the pleasure of having with us Dr. Jatinder Bali sir as one of the associate editors. And of course, a huge editorial board, because we want this to be a truly international journal. We have lots of international researchers and scientists working with us. This was the cover page design, and we started the call for papers. The website was designed. It's a very simple website, gjcsro.com. But when we started asking people and researchers and authors to submit articles, the first question that was, is it indexed? Because that was the NMC mandate, and that continues to be the mandate by the NMC for medical teachers, that your work, if it is published in certain NMC indexed agencies, only then it will be considered for promotions. So that was a big hurdle and big obstacle for us, because unless and until articles come in, issues are published regularly, we fulfill the checklist criteria for the indexing agencies, any journal cannot be indexed, right? So for that, articles have to pour in first. But we were fortunate enough that people did believe in us, and we had this first issue, editorials written by Nayak sir and myself, and we had the issues, and we also had an article from Nigeria, and we could publish the first issue. And this was officially launched in the AIOS2025 at the Geo Convention Center of Mumbai, and the journal then started rolling in. So it's a triannual journal, it's open access, no publication fees as of now, and it's peer reviewed. And every year we issue 3 issues. So 22 we had 3, 23 and 24. And we also have a lot of articles in line ahead of print, which are awaiting allotment of issues. Every year we focus on some particular aspect or a theme. So in 2022 we had a Brazil focused issue with Dr. Harley as the cover page and legend, wherein all the authors and all the articles were Brazilian and focused on Brazilian ophthalmology and their research. In 2023, we had a USA focused issue, wherein all the authors were from US, and Dr. David Patton was the cover page legend. Last year, we had the young ophthalmologist issue, wherein all the authors and co-authors were less than 45 years of age, basically with the idea to promote research and scientific writing in young ophthalmologists. And followed by that, we had the young women ophthalmologist issue, wherein all the authors and co-authors were women, again with the same purpose of promoting research and scientific writing in women ophthalmologists. And finally, last November, exactly at the end of 3 years, we got indexed with the M-based indexing agency. So now that mandate by the NMC, whether your journal is indexed or not, that is fulfilled. So the journey we started at the end of 21, we got indexed in 24, and it still continues. So now we are looking forward to expanding our reviewer database, because with the indexation, of course, more and more articles are pouring in. So anybody interested in becoming a reviewer, want to contribute, you can just log into the website and join as a reviewer or submit as an author. We also look forward to conducting various research and scientific writing activities under the banner of the journal, and of course indexation with other indexing agencies. So I thank everybody who in some way or the other has supported in the journey of the journal, and look forward to everybody's continued support. Thank you.
Thank you, Dr. Puri ma'am, for showing us almost all the highlights and the journey, how our journal becomes started and now becomes an index journal.
Yeah, she deserves a big round of applause because she has done a wonderful task in the past. She is doing and she will be doing.
She is continuing a lot. Next topic is the keynote address from our side, and it's by Dr. Nitin Verma sir. He will be going to give us how we maximize the impact of ISM-ICS cataract surgery outcome on the global stage. Means we are already a global stage, and our founder chairman Sahu sir always said that it is the gift of word from the India. So sir is telling us and echo his own statements. Sir, please.
Thank you. Thank you very much. Look, I'm speaking to the converted, so please bear with me. You know, cataract still remains to be a big problem in the context of the fact that over 1 billion people live with vision loss, and this number is increasing. 100 million need cataract surgery. We won't worry about the rest. And also, if we look at the number of people increasing, the number of cataracts are increasing, and while our capacity is not increasing at the same rate. So look, there the gap is increasing. So given the fact that 90% of cataract blind live in in emerging economies, where are we headed? I mean, we're obviously losing the battle against cataracts. That's because for a long time we've been working on number of cataract surgeries done rather than the outcome, the quality of what we've been able to achieve. Looking at something like the effective cataract surgical coverage, which really tells us what we've been able to achieve in terms of outcomes, I think that's what we should focus on. And really what we find is that there's a big gap based on the socioeconomic status. So if we go on a little further, cataract surgery is one of the oldest surgeries known, and I've had the good fortune of working my way from intracapsular all the way to where things are right now. And one can see that there have been moments where, when extracapsular surgery came in and so on, so things kept moving. And we still have this great debate about phaco versus SICS. And I think it's time to put that to rest, because all the data that we have right now very clearly shows that both surgeries can produce equally good results. So without going into all the data, including the review by the Cochrane review, which basically shows that, a little bit to the left, little bit to the right, but basically both these surgeries are the same. But that's where the comparison stops. And the difference starts now. For example, the cost of a small incision cataract surgery versus phaco, there's a great difference. And in that, SICS clearly wins. Also, when we look at climate change, which is a great problem, and the healthcare industry is responsible for a large amount of greenhouse gas emissions, ophthalmology needs to start working on decarbonizing. In the Royal Australian New Zealand College of Ophthalmologists, we are serious about it. If you look at the number of cases done per day, you produce 1 bag per case of one surgeon, but in a year, this is what waste looks like. So if you're doing 10 million surgeries a year in cataract, can you imagine the waste that we are producing? we've footprinted cataract surgery and looked at the carbon dioxide equivalent emission and find that the amount of surgery of carbon dioxide emission in phacoemulsification is the same as burning 67 liters of petrol. And the major thing is the transport of all these consumables, transport of all the disposables. Now, if we look at the way India does things, I think there's a lot to learn. Why is it so difficult for the rest of the world to go that way? The College of Ophthalmologists in Australia and New Zealand is taking it seriously and has produced guidelines on how to reduce waste in cataract surgery, intravitreal injections, and also suggested a sustainable cataract pack. I won't go into disinfecting tonometer tips, but that's another story. And I think that in Australia, we are really working, trying to produce standards that are acceptable all over the country so that we can, do things. But leave that alone. Let's look at the rest of the world. And now, mass cataract surgery is quite good. And I'm so impressed with the way that small incision cataract surgery is done fast, quick, safe, good results, and backed up by vitreoretinal surgery. So I've done this in Papua New Guinea. You can see this surgery can be done. That's how patients come and go. We've done that in East Timor. So wherever we go, we find that this procedure works. In India, where you do 8.4 million cataract surgeries a year, 55% of them are manual small incision surgery without sutures. But what's happening also, if you look at the RAB study, you'll see that complications of cataract surgery, now this is a little tricky business, are listed, it's listed as a cause for visual impairment. Now, you'd say, well, look, how can that be possible? It's possible because you're looking at comorbidities, you're looking at lots of uncorrected refractive error and so on. So if you try and see what's happening for cataract surgery in Australia, it's almost like a refractive surgery. But still the main cause for poor results remain concomitant disease and residual refractive error. So, it's important that we address this, doesn't matter where you are. And also to answer the question that is it worthwhile for surgeons who routinely perform phacoemulsification to learn SICS? I think the answer is yes. And for that, I would say thank you very much to the International Society for Manual Small Incision Cataract Surgery for opening a branch in Australia and New Zealand. The president is sitting right here in the middle, Vignesh Raja. But look, we have taken things forward there. We run courses, we run lectures. We had younger ophthalmologists wanting to come and learn SICS. And not only that, we've extended our outreach to the Pacific and have really worked on improving outcomes of cataract surgery as a specific project. We will continue that this year. Here are some photographs from a workshop in Fiji, and Parikshit came for that. He impressed them so much they want to open a chapter in the Pacific also. But that's how it did, and I tell you, it was very well sort of received. And I think some of the things that really come up, the important part is not the surgery. The important part is the journey of the cataract patient, from case selection to management of complications. And that's what we should be looking at. Get better biometry, better management of comorbidity. Better surgery is fine, we always concentrate, but better management of complications, and of course, auditing. I think it's time when we need to stop this debate or this quarrel, because in the end, we'll find that who suffers? It's going to be the patient. So, again, to the question, are we winning the war against cataract surgery at a global level? The answer is no. And now with the changes that have come in the world, with the way help is given and assistance is given to countries, we really need to think, because this is a time for us to recalibrate the way we do things. It's not going to be business as usual anymore. And I think as we move forward, we need to focus on good vision and try and achieve the Sustainable Development Goals of the United Nations, none of which will be possible without good vision. So I think that's really where we need to go. We need to look at the whole journey. We need to look at the outcomes. We need to look at the carbon footprinting and the sustainability of what we do. And for that, I would commend the society for working in that. So Thank you so much for your attention.
Thank you so much, sir. As we, any question, we can, if anyone wish to ask any question, we can take one or two questions for sir.
Thank you.
We can go for the next speaker.
Thank you.
So as we all know that in SICS there are different methods of nucleus delivery, and one of the exciting and new thing about the nucleus delivery is the next method, which was invented by our executive chairman Dr. Boramani sir. Dr. Boramani's Indo-expression of the nucleus. I am going to invite Dr. Kimaya Chauhan to highlight us on this new technique which is invented by Boramani sir.
Hello everyone. At the outset, I would like to thank the organizers, Dr. Sahu, Dr. Boramani, for giving me the wonderful opportunity.
Audio visual, please play Dr. Kimaya Chauhan's slides.
Dr. Kimaya.
Kimaya Chauhan.
Yeah.
Yes.
So let's start. Dr. Boramani's Indo-expression of nucleus. So every one of us knows that there are two specific methods of taking the nucleus out. Either they are pushing techniques or pulling techniques. In pushing, we have AC maintainer, irrigating vectors, and visco-expression, where we push the nucleus from inside out. And there are pulling techniques, where we pull the nucleus out from the tunnel, like fish hook technique, vectors, delivery, phaco sandwich, and serrated forceps technique. So in endo-expression now, let's go and see. So this is the way, basically the principle is. Your Sinski hook pushes the nucleus out of the anterior chamber, and you can see here, the basic principle here is the nucleus has to be in the tunnel, okay? You have to engage the nucleus in the tunnel, and then only you have to insert the Sinski hook inside the anterior chamber. And when you do this, your endothelium is quite away from the nucleus, so it will not have any bad effect on the endothelium. So unless the nucleus is engaged in the tunnel, you are not supposed to give any pressure from the anterior chamber to the paracentesis. That is the basis of this endo-expression technique. So you can see here we are taking into account the elasticity of the sclera. So the nucleus once is engaged there, and when we push it from the paracentesis with the Sinski hook, the nucleus comes out when you give pressure on the posterior lip of the sclera. So you are taking two different things. First, of our pressure from within the anterior chamber, and second is elasticity of the scleral tunnel. Okay, so this is basic principle. So I am repeating again, the nucleus has to be engaged in the tunnel, otherwise you don't do this, okay? You will tend to damage the endothelium. Okay, so let's go ahead and see. I will play the video here. Yes, now, yeah. You are playing the video for me, or should I? It should play. Is it playing? No. That's what.
You can.
Play the media. Yeah. Yeah. Are you playing it?
Or you can try the next video.
Okay, I will try. Okay, let's go ahead and do it. Okay, fine. So this is the basic way how you go ahead with tunnel. Now this tunnel looks a little different. It is something like a horseshoe shaped tunnel. This is a specific tunnel made by Dr. Boramani, because he actually does it all surgery that's customized incision cataract surgery to get post-operatively nil astigmatism. So the technique is CICS, what we call. My colleague Neeta is going to explain it by tomorrow. So now here from paracentesis we are getting the Sinski inside, and then it is pushing the nucleus out. So now here the nucleus is engaged first, and then it is pressed out with the help of the Sinski. So as I was saying, it is engaged first, and then give a posterior lip pressure, and the nucleus comes out very easily. So here we are using even AC maintainer, no visco at all. So this is one more case Here's the media. Yes. Now we are going ahead with tunnel making. The same. The same or this? Yes. Now it shows you the exact millimeters, hardly 4 millimeters. Very hard nucleus with a cement on. Now we are pushing the procedure of sclera. Yes, and with the help of Kaczynski again, we'll try and go ahead with the endo expression. Just one more case to show. Yeah, now this is one more where we might go ahead with some visco delivery. So first where hydro endo expression. Here we are injecting visco, so that now it will be visco endo expression without taking the AC maintainer. AC maintainer will be out now. So you can do it under visco or under AC maintainer. Okay, this is a temporal SICS. Even you can go ahead and do it in the temporal side also. So it can be done even temporal, and also the other case, it is superiotemporal incision. So all these incisions are on different sites to control the astigmatism, and how it is controlled, you have to come for the tomorrow's session, okay? Magic of SICS 2, yeah. And this technique has actually been published in November 22 issue of IGO. So very, very good news for us. And Dr. Boramani has actually received an award for it as a Best Innovation Award. So I should actually again congratulate sir. And so in short, we have all different techniques by different pioneers amongst us. Whichever technique is good in your hands, you go ahead and do it. The basic principle or basic thing remains is we have to give visual prognosis, which is the best in our hands. Okay, so you can go ahead with any of the techniques. Thank you so much for the patient listening. Thank you. And yeah, don't forget that one more slide was there, that we have a CCC coming up, okay, in collaboration with AIMS. So we are expecting all of you to be there in CCC next year, April. Thank you.
Thank you, Dr. Kimaya, for nicely elaborating that. Thank you, Dr. Kimaya, for nicely elaborating that technique. I now invite Dr. Manisha Rathi for elaborating the different incisions that can be tried in SICS.
Thank you so much. Absolute honor to be here. And it is so heartening to see these packed halls for SICS. So thank you to Dr. Sahu sir, Dr. Boramani sir, who have made it possible. And just a small thing, the reason I've come late is because my team from Haryana has been the winner, and we are appearing in the final TOT competition. Need your blessings for that. So why do we do SICS? First of all, it is a surgery for any cataract at any time in anyone's hands. And also, it has a shorter learning curve, it has a lower cost of equipment, a shorter period of training, higher safety, and also for high volume setups due to the relatively faster technique and less endothelial cell loss. We are now going to do a study on phaco versus SICS for the same hardness of cataract regarding endothelial cell loss. We have started it. It's very encouraging results for SICS. It also has a self-sealing incision with tunnel, and also a simulation-based training is available for SICS, and it's the only way to address complete avoidable blindness. As we all know, surgically induced astigmatism is the key factor in deciding the incision, but the best thing, the idea given by our founders and stalwarts is that we can use surgically corrected astigmatism. So we can actually correct the this is a typical tunnel which had been made by me, has been published. So as you can see, this is a hard cataract because I'm in a government institution. So obviously my profile of patients is of a lower socioeconomic status, illiterate, and they present later. So this is the tunnel with 7 millimeters overall and a 3.5 millimeter depth. So irrespective of the preoperative astigmatism, in my experience, we had a frown group and the chevron group. The chevron group, this was published in AIOS in 2022. It was 0.32 diopters plus minus 0.27 diopters, which is very encouraging. Even in other studies, you can see that the chevron incision has given the minimum astigmatism, but I said now we are using the concept of surgically corrected astigmatism. And this is a typical patient who came to me. As you can see, it is a hypermature cataract, so I'm making the chevron incision at the limbus, elderly patient. And these instruments do not cost much at all. This is the disposable crescent which we are using. So dissect, you should be able to see the blade at all times, 50 to 75%, and the entry with keratome, of course. You have to stain the anterior capsule in all these patients. Since it was only the incision, I have stopped there. And this is another elderly, the same profile of patient. That was a white cataract. This is NS 4 to 5, so I'm making a wider chevron incision in this. I think the key in all these incisions for minimal astigmatism is to keep away from the limbus. It is a little more difficult to dissect, but I remain 2 to 2.5 millimeters away from the limbus. I have seen a lot of patients complaining, a lot of people complaining about astigmatism, and when I say, okay, let me take a look at your surgery, so they are making right almost at the limbus. They're calling it 2 millimeters or 1 millimeter, but it is almost, because that is the easiest to do. So this is the typical incision. This is in a young patient. You can give a much steeper incision for zero astigmatism. So you can see that you don't expect the hardness of the cataract to be that much. So the incision you give depends on how much space you need. And this I'm really, actually 2.5 millimeters away from the limbus with the steeper incision. This was a lady, a young lady. She had zero astigmatism preoperatively, and at the end of the surgery, she again had zero astigmatism. And so that was one happy person who came back for surgery to the other eye. This was her tunnel. And another patient. Okay, so this is another patient which I gave a straight incision to this person because we wanted to induce some astigmatism. So I actually ended up inducing around 0.75 diopters of astigmatism. And the tunnel is made the same way. You make a good scleral as well as the corneal part by dissection. Keep in the same plane. Do not make multiple. This is a person who came to me, the typical profile of patients. Previously operated case of trabeculectomy. I'm doing another site. I am not doing at the site of trabeculectomy. So I'm doing it from the temporal side with a hard cataract, non-dilating pupil, synechiae. So I decided to give a straight incision because we already had enough confounding factors. As you can see, the patient, the incision, there was some bleeding, but it did not go into the AC. The surgery finally was uneventful. We used ADR as well as a high viscoelastic substance. This is another patient with a straight. I used to find it very difficult to make a straight incision because I thought it was inferior to the others. But now you play it another way. You use it for the astigmatism. This is no talk would be complete without Dr. Sahu's and Dr. Boramani's technique. So this is his 2 millimeter technique taken from the internet. And I've shown to all my students. Some of them have decided to start trying this now. They're just trying to acquire the instrument required. And of course, this gives excellent results. I see a lot of people here who are already doing it. So next time, next conference, we shall be there too. And this is Dr. Boramani's on-axis technique. As you can see, only when you're very experienced like both of them, you can make this kind of incision. So you can start with an on-axis, you can start with a straight incision. My students find it easier to start with straight. I always encourage them. And then we always, do the post-operative keratometry, writing it. There's no proof like the written proof. So we write down the astigmatism, and they feel very encouraged because they feel very great doing a phacosurgery. And you can put any type of intraocular. So they said, ma'am, no, the patient has a premium lens. So I said, why can't you put this? So I said, okay, let's do this. You do in one eye your choice of surgery, the glamorous one, and the other eye do my poor man's type of surgery. And we'll see. And because of that, a lot of my students are doing small incision cataract surgery. Thank you so much for having me here. Yeah.
Thank you, Dr. Manisha, for excellently covering the incision. And I would like to say it's not a poor man's surgery. I think more SICS surgeons are charging more than the phacoemulsification surgeon also. So coming to the next topic, in SICS definitely training is required, and one of the mode of this training is simulation. So I request Dr. Jatinder Bali to speak on simulators in ophthalmic surgical training. The discussions will take at the end of the topic, so I request all the discussants and the delegates be here for any clearance of the doubts.
Good evening, ladies and gentlemen. At the outset, I want to thank ISMSICS, the founder members, Dr. Sahu, Dr. Boramani, Dr. Deepak, and the Asia Pacific Academy of Ophthalmology, the All India Ophthalmology Society, for giving me this opportunity to talk to you about simulators in ophthalmic surgical training. Well, today I'm going to tell you the story of, it's a very interesting story of a man who fell from an aircraft while teaching somebody how to fly an aircraft, landed on power lines below, and from there to the ground without a parachute. He survives that, and after that what he does changes the way we train pilots. Then he goes on to change the way we perform cataract surgery, and then how we train our people how to perform cataract surgery. I have no financial disclosures to make for this presentation. The first question that comes to mind is, why are we talking about simulation today? Well, we talked of reducing errors. We don't want a rookie pilot to learn landing an aircraft with a fully loaded aeroplane in which you are traveling. Would you like to do that? Any one of you? No. So that's exactly what we want to do. We want to give a risk-free environment within which repetitive practice can be performed to reduce the surgical errors, increase the confidence of the rookie surgeon, develop his skill, and retain that skill. There are many examples of different simulators which are available. I won't name them. We will be focusing on one of them because Help Me See has a simulator which has simulation training for manual small incision cataract surgery. So I talked of a pilot, I talked of how cataract surgery got changed, and I talked of simulation. Disparate things, but allow me to start my story from the very beginning with Alfred Yulchi. He was the founder of Flight Safety International, which was a pioneer in modern flight safety simulation training, and he is one of the heroes of aviation, ranked at number 13. Now, so far as Yulchi's early life is concerned, he was born in Kentucky in 1917. At age 16, he starts selling hamburgers in a hamburger stand called Little Hawk Hamburger Stand. And do you know why he's doing that? He is trying to raise funds for his flight school. From the profits of that hamburger stand, he purchased a Waco 10, learned flying, funded his flying from these profits, became a flight instructor, was hired by the Pan American. Then there was that very famous incident that I talked of, and he founded Flight Safety International in 1951, which has the motto, the best safety device in any aircraft across the world is a well-trained crew. So how is it related to this video at the bottom that you are seeing? Is the simulator in action, in practice. And he has been instrumental in development of the simulator. Now, Flight Safety International, what did it do? It initiated a training revolution by identifying the gaps in corporate pilot training and then developing realistic flight simulators. This particular company became very rich and was subsequently acquired, and Yulchi moved on and founded something called Orbis International. He was one of the co-founders, and he got involved with the Flying Eye hospitals, which conducted large number of cataract surgeries across the world. That was where he realized that there was a shortage of well-trained cataract surgeons. He saw a potential in simulation-based cataract surgery training. And from these funds, he initiated, laid the seeds for Help Me See. And we have some of the pioneers who started the journey with him. And it is today a complete training suite which is there. We have a Help Me See India team, some members of which are here present, led by, I think, Dr. Chetan Anewale and Dr. Kemea. And many of our members have been instrumental in the development of all these modules that we're talking of. It is also, we have been part of the collaborative training program in training cataract surgeons using these, using the simulator. We've already talked of what are the benefits of using this. Cost effectiveness and reduced stress on the surgeon is one of the key takeaway messages in terms of the use of the simulators. The future of training is definitely augmented reality and virtual reality. Albert Yulchi is no longer with us. He's passed away around 10 or 12 years ago, but his legacy lives on. His life epitomizes, the change that one single human life can bring to millions of people across the world. And I love it when Dr. Sahu tells the youngsters that you choose what kind of a legacy is it that you want to be remembered by. So my exhortation to you, as is with him, is choose wisely. Thank you, ladies and gentlemen. That was my time. I hope I've done justice to the subject. Thank you, sir.
Thank you, Dr. Pali, sir.
Thank you, Doctor. I had the privilege of meeting Mr. Al Yulchi in AO 2011 when they had parted from Orbis, because Orbis would be doing a lot of training, and Al Yulchi believed that training conventionally was not perhaps the way to solving the developing world's problem, and we needed to completely think differently. So even though he was the founder of Orbis, after spending 25 years there, the Orbis board was vertically split and Help Me See was found. And that way, India or Indian software played a small role, because for the first 5 years, this simulator was developed in the city of Pune in Hinjawadi. So it was Indian, US, Czech and Finnish collaboration which made it. And of course, Chetan and Kimaya and our own, your lead, the first ones, they are the ones who had started and worked on it. And now it is not just for SICS, because they realize that it is one part, definitely, but there is so much more to be done. Because when we look at all RAP surveys around the world, the fourth or the fifth leading cause of blindness is cataract surgery complications. Yeah, so we ophthalmologists also have to do it, and I think that is where ISM-SICS with its quality surgery comes into picture.
Thank you, Dr. Parikshit, and thank you, Dr. Pali, sir, for linking the history to the present and future. We've just heard about different nucleus techniques, and in SICS is one such surgery where practically every second, third surgeon has their own way of nucleus delivery. So now I invite Dr. Anil Shah, sir, to discuss his snare technique for cataract removal.
today we are presenting Magic of SICS, snare, a revolutionary approach to cataract surgery. I am really very much thankful to the office bearers and organizing committee of APOS and AIOS for inviting me as a speaker. Now, the ultimate aim of any cataract surgery is that incision site should be close to phacoincision. We are almost competing phacosurgery. So if our incision is close to phacoincision, then the technique of SICS is much greater. The technique should be simple, it should have minimum learning curve, and it should divide all grades of cataract. Now, cataract surgery is no longer a rehabilitative procedure, but it is extremely precise procedure, and it is a refractive surgery. And our aim is emetropia with multifocality and phaco-free MSICS. Now, snare technique can be indicated for all types of cataract. Whatever the type of cataract you label, you can do with the snare technique. And last is when there is a phaco machine failure, you can do a snare technique also. This is my snare design, which I am using for last 35 years. And this is the same snare which is practiced by me, and it is used by all of us. Now, the special feature about a snare technique is that it has got two holes at the tip, which are very useful. Because of these two holes, the loop size can be adjusted. Intraocular rotation is possible. Intraocular movement is possible. Easy engaging of the nucleus is possible. You can divide any grade of nucleus. There is a safe division. And another thing is that it can be autoclaved multiple times, so the snare can be used many times. Now, when to avoid snare is also an important factor. When the eyeball is hot, there is a positive pressure. If nucleus is not free floating into the anterior chamber, if AC is not adequately filled, and if AC is shallow, if there are intraocular movements are present, and if the surgeon is confident. Always use snare with OVD, do not use with BSS or saline. Now, there is some unknown fear for snare technique. There is a common fear, some misconceptions are there, some misinformations are there. Some think that there is steep learning curve, some think that it can damage cornea, posterior capsule or iris, and some think that there is limited control on the procedure, and some fear is unknown. But actually it is one of the most safest surgery. There are many advantages of snare technique. I will not go into the detailed advantages because this is one of the best technique for delivering any grade of nucleus to a smaller incision, so it has got very multiple advantages. The unique feature of snare technique is that the snare is the only instrument that can give a longitudinal division of any grade of cataract, and a complete division of the posterior plate is possible at one go. Now, snare versus there are many pre-choppers are available. The nucleus division by pre-chopper is pie-shaped, so the size of incision is more. But here in snare, you get a longitudinal division, so you can take the nucleus pieces to a very small incision. In pre-chopper technique, there is a risk to bag, zonular dehiscence or precedent, but it is safe with the bag, zonules and precedent. And posterior plate is difficult to break with the pre-chopper, but it is easy to break posterior plate with the snare technique. And snare technique is in the safe zone, while pre-chopper is in a risky zone. Now I'll show you the video. This is my routine way of doing transconjunctival limbal tunnel incision. Normally I use 3.5 millimeter to 4 millimeter. External incision is smaller and internal incision is little wider. The nucleus is prolapsed into the anterior chamber. It is made free floating into the anterior chamber. It should not be attached to any intraocular structure. OVD is filled around the nucleus, below, above and in the sides, so as to make the nucleus stable. Now the snare loop is made shorter according to the size of the nucleus. The loop should be of adequate size. If the loop is big, then it can damage endothelium. If it is small, it will not engage the nucleus. The loop encircles the nucleus and divides it in a fraction of a second, and you get a two clear-cut division of the nucleus. The two halves are separated. Normally, I remove all these types of nucleus with a simple plain McPherson forceps. A thin, long McPherson forceps is sufficient to remove all these types of nucleus. There is no damage to endothelium, no damage to posterior capsule or even the tunnel, and you can safely remove the nucleus with the McPherson forceps. The another half of the nucleus is brought into the center. many things that a snare can touch the endothelium, but it is not so. It is very safe to the endothelium. Now this is an intimation cataract. These types of cataracts are also very difficult to manage with the other methods of cataract surgery. Now with the snare, you can divide this nucleus easily, and the incision size is almost 3 to 3.5 millimeter. So you can take out this type of nucleus very easily. This is a very small nucleus. I have removed a core embryonic nucleus. Almost all the EP nucleus is not there. So this type of nucleus, you can divide it into 2 incision or 2 fragments or 3 fragments. This is a very big nucleus which is occupying whole of the anterior chamber. These type of cases are also very difficult to manage, but with the snare technique, you can do bisection and trisection and remove through the smallest incision. See, this is one fragment is done. Now the snare is engaging the other half of the nucleus, and the nucleus is divided into 3 fragments. Here it doesn't touch the endothelium or even to the posterior capsule. Now these fragments are removed by the McPherson forceps easily. This is a middle fragment, and you see the incision size is almost 3.5 millimeter. So with this we can do all premium IOLs, all types of cataracts, and you get a good results in multifocal and trifocal IOLs also. Here in this video, I will show you how the snare can be used. Here is quadrisection is done. 4 sections. Here in this video, I will show you how the snare can be used to divide nucleus into 4 sections, quadrisection. Now, normally quadrisection is not routinely practiced, but if the nucleus is very hard and if you want the incision size should be less than 3 millimeter or 3.5 millimeter, then you can use snare to divide the nucleus into 4 segments. Normal nucleus size is approximately 9 to 10 millimeter. So after 4 division, the size of the nucleus becomes 2 to 2.5 millimeter, which can be easily removed through a 3 or 3.5 millimeter incision. So your incision is close to phaco incision, and you get all the benefits of phaco incision. See here, after division, the nucleus fragments are being removed by McPherson forceps. This is the last fragment which is removed. In this another case where I was supposed to do trisection, so I did a first section and divided the nucleus into 2 halves. The other half of the nucleus is big, so I thought of dividing it again into another fragment. So this is another section and the nucleus fragment is divided. But when I tried to remove this fragment, it appears to be slightly bigger than the size of the wound. So I again divided it into another section, and that way 4 sections are made. And these 4 fragments are removed through 3.5 millimeter or 3 millimeter incision with the McPherson forceps. This is very simple, safe, and a good technique for all types of cataract, and it can be removed through smallest incision of 3.5 millimeter. So these are the post-operative cases after day 1 or in 1 week, and I have done almost 25,000 cases of with the snare technique. Initial difficulties are there like corneal edema and descending memory detachment or hyphema, but with the practice they subsides. There is no PCR or no nucleus draft. You can do it in this surgery in 10 to 15 minutes, and the recovery time is also 2 to 4 hours. Patient can be discharged in 2 to 4 hours. So it is as good as you are doing a phaco surgery. So in conclusion, it is a revolutionary approach to cataract surgery, precision and safety and efficiency to make it invaluable tool. My presentation has inspired you to explore this technique and incorporate in your practice. Together we continue to push the boundaries of what is possible in eye care to improve vision of our patient worldwide. Thank you.
Thank you, Dr. Anil Shah, for giving this elaborative demonstration of nucleus management through the snare technique. Now we are coming to the very important topic. Is it possible to do a topical MSICS? So we have Dr. Jayashree Barua to say on that. And we'll take the questions at the end of the session.
Very good afternoon, everyone, and thank you so much for being here to listen even to the last talk of the day, I think. All of you I know have been present here since morning, and I know it's a tiring, it has been a tiring day for everyone. Can I have my slides, please? That side? Okay. Yeah. So I'm here to speak on not how the technique of SICS, but I am basically going to deal with how can we shift from peribulbar to topical anesthesia. So topical M6, the tips and the tricks for doing these cases. And why topical? Because we are doing our FECO cases and the patients, they go off at the end of the day without having a patch. So why don't we give the same opportunity to our SICS patients? Why discriminate with them? So ultimately, it is the form of low risk and non-invasive technique, but it's ultimately a personal choice. It depends upon you, whether you want to actually shift from peribulbar to topical or not. It's you who is going to decide whether to shift to topical or not. Now, is topical anesthesia safe in M6? Is it actually possible to do M6 under topical anesthesia? Can we do it in all the cases? And do we need to modify our surgical steps when we are going for topical anesthesia? Now, we have been doing our SICS cases under peribulbar anesthesia. We have wonderful echinacea. We have wonderful anesthesia. So do we actually need to move out of our comfort zone? We are having a comfort zone with peribulbar anesthesia. Like every technique, there should be a scope for improvement. And anesthesia is no different. We need to improve our anesthesia techniques also. But it's not that one fine day you decide to jump into topical anesthesia. Now, I decided to sit back and analyze my own surgical cases. So I realized that it was after my 30th case of phacoemulsification that I shifted to topical anesthesia. And it took me 40,000 SICS cases to shift from peribulbar to topical anesthesia. And I was doing my SICS cases in 3 minutes. I was doing it under peribulbar. I was completing my FECO case in 8 to 10 minutes, and I was doing it under topical. So what was the difference in my surgical technique? What am I doing differently for the patient? So why I didn't go for topical M6 earlier? Now, was I worried that it will be painful for the patient? I was at that time using the superior rectus brittle suture, which I don't use now. Will it be difficult to manage a hard nucleus? What if I land up in a complication? What if I have a PCR? Will I be able to manage it? Or was I simply looking for an excuse for avoiding maybe topical anesthesia? So I decided to brush up my anatomy a little bit and study about this. So I realized that it was the sensitive terminations of the fifth cranial nerve, and these are concentrated in the cornea and the ciliary body where we are actually operating. And these nerves are blocked by a very low concentration of drugs in comparison to your motor fibers. The advantages, we all know it has a higher safety level, a better consistency, you have a lower intraocular pressure, and the best part, the return of sensitivity immediately after surgery. Yes, limitations are there. Initially, you have to choose cooperative patients. You have to choose easier cases. When you know that your surgery is going to take a long time, you're anticipating a long surgery, or you know it's going to be a complicated case, better not jump into topical immediately. You can very well go with peribulbar anesthesia. And the proparacaine drops are readily available nowadays. We have wonderful intracameral injections which work wonderfully with both analgesia as well as echinacea. So the technique is the simplest of all. You just ask the patient to look up. instill or drop into the fornix, avoid the cornea to avoid the corneal toxicity. Just ask the patient to close his eyes and your job is done. And initially, an important tip is that initially when you are starting your topical anesthesia, you can apply these drops to both your eyes so as to prevent the squeeze response of the patient. Now there are 3 ingredients for success of topical anesthesia. You have to prepare your patient, you have to select your patient properly, and you as a surgeon, you have to prepare yourself for the surgery. So regarding patient preparation, the adequate preoperative counseling is very important. You have to remember 4 important things. That the microscope light initially appears very bright for the patient. So start with a dim illumination, we can see in the first video, and then gradually you can increase your illumination. Now, the patient, remember that still has intact eyelid sensation. This is another important issue. Eye movement control. It's better if the patient can understand where you want the patient to exactly look into. And also, it's very normal to feel some pressure sensations inside the eye. So this you need to explain to your patient. Patient selection is the next most important thing. So the patient should be able to understand what you are saying, what you want. You choose the easier cases initially. Check for the squeeze response of the patient, and how you do this when you are seeing the patient in the OPD, you're doing your routine procedures, like maybe you're doing your AT or other procedures. If your patient is not cooperative, then this patient might not cooperate on your OT table. So next is check for whether he can completely follow the eye movements. So with pre-operative counseling and careful patient selection, you can definitely maximize your chances of success and minimize the stress factor both of the patient as well as you as a surgeon. Now, how do we prepare ourselves? Here again, there are 3 issues which I'll be dealing one by one. Sorry. So saccadic eye movements are disconcerting, but when it's a more sudden and forceful movement, it definitely becomes difficult, and here you need the patient's cooperation. You have to be aware that the patient has intact periocular sensation. Can I just take a minute or so? Okay. Okay. So stimulation of the eyelids or a subconjunctival injection or a traction on the speculum might be painful for the patient. The iris retains its normal sensitivity. So at this point, when you're taking out the nucleus, initially you can go ahead with the intracameral injections. So the deciding factors is always the patient, how he is going to cooperate with you. You as a surgeon, how apt you are in shifting from peribulbar to topical. It's your skill, your experience, and also the type of cataract that you are dealing with. So these are the immediate post-operative pictures of few of my patients, and the basic harm before adopting any technique is to advocate, before advocating any procedure is not to do any harm to the patients and see the smiles in these beautiful faces. Let all our SICS patients have the same comfort level, enjoy the same advantages as our phaco patients. And hope this presentation could provide a little bit of confidence in everyone to shift gradually from peribulbar to topical anesthesia. Thank you so much.
Thank you, Dr. Jayashree, for those important tips and trips. So with this, we come to the end of the talks for the session. We open the house for any discussion. So if anybody has any questions to be asked to the speakers, yes, please, Dr. Parikshit.
I just wanted to make a comment, 2 comments. I mean, we've seen fantastic surgeries, Dr. Sahu's, Dr. Boramani's, Dr. Kimea, Dr. Anil Shah, who's like a magician in many ways, Dr. Jayashree, Dr. Chinmay, Dr. Manisha. But I would like to say, as a ordinary cataract surgeon, is that we should be, SICS is in many ways a more complex, a surgery where you have to use your mind more than you have to do it when you do a phaco. So it's a surgery that has to be done with a lot of thought, with a lot of selection in how we want to do it, because otherwise we can have persistent corneal edemas, which a lot of our clinical audits show. So, I mean, we have like fantastic surgeons, like we have great players, Tendulkar or Michael Johnson or somebody, but it has to be done with a great deal of thought and caution. That's one. And second, Dr. Jayashree showed doing topical anesthesia. and which also needs a lot of skill and patience both on part of the patient and also the surgeon, both of them. And there is a very good Laninder test, the looking down, lying down test, and there is Dr. Vimal Rajput who has done a randomized control trial on it, and he has shown that how we can actually find by doing an indirect ophthalmoscopy whether this patient of SICS will cooperate well for topical anesthesia or not. And he has done it with augmented this. So it's not just topical. When in phaco we say topical, it just drops from the top. But in SICS, we also do a lot of things, and we don't have the machine to help us. So giving a small amount of parabulbar, using a small amount of intracameral, and also then doing a topical, it helps in a long way. But
Yeah.
of course, it's the magic of SICS. So even past 6 o'clock, we have a hall still full for the ISM SICS.
How many of you feel that SICS is a lesser surgery compared to phaco? Just raise your hand. Why? Why you think it is a lesser surgery compared to phaco? So
No,
it
no,
is a
the
less.
question is that you feel the SICS
Inferior,
is lesser
inferior,
than phaco? Phaco. Inferior to
Not
phaco.
lesser.
Huh. No, sir.
No,
no
I
one.
want this house to go with the feeling that it is a superb surgery. Only thing you have to learn the right way from the right people, and the result is really superb. The world is working up, and never feel inferior. Think you are an artist in the cataract surgery. Your take-home money will be much better compared to phaco. And phaco people with their autoclaving and so many instruments, infection chances so much, and SICS surgeon can sleep quietly and with a money bag in their pocket.
No, sir. And with the ISM SICS movement, even people who may feel that perhaps it's inferior to phaco now will not speak out in public.
So that is the
saying
message I wanted to give. That is the message I want to give you. You feel proud about your art. That's all.
It is lesser as far as, 1 minute. It is lesser as far as the time is concerned. You can done it very quickly.
Dr. Sujata,
Yeah.
please come
So-
on the mic for your comments.
From the audience, whosoever is interested in contributing in ISM SICS, we are organizing World Conference every 2 years. The conference is called as Comprehensive Cataract Conference. We have tied up with big institute in the past, and our next conference will be hosted by RP Center, All India Institute of Medical Sciences in Delhi in November. So if you really want to take part, even the juniors, beginners, everyone can take part, please contact us. Those who want to contribute to the journal also can contact Dr. Purvi or visit our website. We want to take the comments from the discussion, Dr. Sujata and Dr. Rajvinder, and maybe the final comments from the chairman, ISM SICS, Australia and New Zealand, Dr. Vignesh Raja. Please, Dr. Sujata.
I would just like to add that in
Oh, sorry.
times of integrated learning, when we need to go vertically and laterally, I don't think we are there to compare with each other. We are here to complement with each other. So the ones who are learning to go for the phaco way, they ought to know SICS. Likewise, the ones who are practicing phaco at times need to do the SICS as well. So I don't say what is superior and inferior. I think it's like we need to know how to drive the manual car and also the automatic.
Correct.
Because when you go to a place when you don't have, sometimes the machines stop working in places of India where you have the lights going off, and there are times when we need to resort to just a focus light or maybe even a torch, and patient is already uncooperative. So even if you are into that stage, we just extend. And being into a teaching hospital, there are many times we need to resort to convert the phacos to SICS. So I think that is the need of the hour. One ought to know all kind, whichever vehicle comes your way, you need
Correct.
to drive. So you need to know all your techniques well.
So instead of
Thank you.
talking as phaco surgeon or SICS surgeon, we should be a complete surgeon, learn everything. But in all conferences, you hear the talks, how to convert to SICS in case of phaco. Even today also you'll learn. But you will never hear a talk how to convert to phaco in case of difficult SICS. So this means that SICS covers everything.
Very good point, sir.
It is for black, white, black person, white person, rich person, poor person, for everyone it is there.
So, Mr. You first.
Professor Ravi Thomas, he has written in an editorial in the Ransco journal that a phaco surgeon who does not know SICS is like a pilot who does not know how to use a parachute.
Yeah, that is very true. So, when we think of shifting from the peribulbar to topical, we can in between we can shift to subtenon injection, posterior subtenon. They can be tried in between, so that that is very good way to shift to topical anesthesia for doing small incision cataract surgery. You so want to add something?
Yeah, I think. Can I?
Yeah.
Yes.
See, in case you're going in for topical and you've already opened the conjunctiva and you have an intracath with you, so you just go use the intracath and infiltrate the subtenons. In case the patient is not cooperating with you, just use a little bit of subtenons. Over a period of time, you'll be able to, actually titrate. There are a lot of people who actually prefer to use subtenons as the main modality for.
Always use subtenons.
1 to 2
Yeah.
2 cc. That is all.
So once you tell patient it is no injection surgery, it remains no injection because patient will not come to know about that infiltration, what you are talking.
Dr. Vignesh, final comments from you, please.
No, in fact, I wanted to make 3 points. In fact, I would say that a cataract surgeon is not a complete cataract surgeon if they do not know how to do both SICS and phaco. Because like all the talks today have shown, and experts from the audience and comments from the audience have shown, that we need to be versatile enough to do both SICS and phaco to complement each other and to customize it to the solution, customize it to each patient to what they have, and more than bailing out, I think we should do what's best for the patient. And a surgeon is not a complete surgeon if they do not know both techniques. And I think it's a very good point. I think we should move out from peribulbar anesthesia completely, because there is that very small risk of globe perforation, in higher axial length or patient moving. I think subtenons is much more safer, and I think when we are transitioning from subtenons to topical, I think we could go subtenon and then even go subconjunctival and then go topical. And in fact, when I was training in the UK, what we used to do is we used to use the lacrimal cannula, which we use for syringing, and syringing. We use that to give anterior subtenons, so it makes no, nick in the conjunctiva, and it's very, very safe. And I think, and like my chairman, Professor Nitin Verma alluded to, I think the biggest aim right now is sustainability in cataract surgery and the carbon footprint. The each phaco surgery, and especially in the West, when everything is use and throw, the amount of carbon footprint is generated by each cataract surgery by phaco is about 20-25 times that of a simple SICS, and with climate change, I think that is the way to go.
So we have 5 more minutes left. We can take the questions from the audience. Yeah.
Are we justified in charging the same for SICS and phaco?
Yes. Yes.
I think it's the result that matters at the end.
Yeah.
Yeah.
In fact, the highest charges in India are for SICS. It is 3 lakhs for a monofocal
Dr.
lens.
Deepak, you want to say something?
With SICS.
And
So what Dr. Sahu said, your take-home money is more in SICS.
I think the other point is,
Yeah.
the other point is the SICS patients, because we are mainly doing them in black or brown cataracts, they go from counting fingers to 6'9", and they're much more happy than a phaco patient who goes from 6'18" to 6'6". So, and these guys will be happy to pay anything when they get this much vision back, because it's the quantum of difference that the vision has made.
Somebody is on a study on, the patient happiness index kind of a thing. How much is he willing to pay for that kind of a happiness?
On the contrary, I feel we should be charging more for SICS, because that
Exactly.
is all about surgical skills and not about the automation that is there.
Yeah. When we are taking the cost from the patient for our machines, why not take the cost for our expertise? Because I feel it's like having a beautiful handwriting, or painting a beautiful painting. So it's your skill. When you are charging for your machine, why not charge for your skill that you are giving to the patient? But yes, you have to give the best of the result to the patient.
Honestly speaking, Exactly.
Yes. Patients never ask which technique you are doing. Yeah. I am doing 100. Yeah.
You always ask which lens you are putting. So put the lens and take the cost. Laser se kar rahe ho. So then put the foldable IOL and
Looking to the
See, I am
enthusiasm that is there around MSICS, I just want to make two announcements. We have a managing astigmatism with MSICS IC tomorrow, 8 a.m. Gulmohar Hall. And the second part of this Magic of SICS, talking about customized incision cataract surgery, 245 Neel Kamal Hall tomorrow. So hope to continue the discussion tomorrow morning and afternoon as well.
Yeah.
And I would request all the speakers please to come over for a group photo.
I have a question. Regarding carbon footprint, if we talk about in phaco and SICS, if we are using an autoclavable tubing, how does it make much difference to the carbon footprint? It is about the PP kit and other things
no,
which
no,
can
because
be used in
phaco, the fluid that is used is more, the visco that is used is also more. And in the Western world, sir will say a lot of it is use and throw.
The carbon footprint is directly proportional in this situation to the transport of all the consumables that come, and also don't worry about the machine. We'll wait for it. And the electricity that's used for everything, the carbon footprint of 6 kilograms as compared to 150 kilograms.
In fact, most of it is it's in fact 200 kilogram plus, because everything is disposable there, and you can do an SICS with 15 ml of fluid, 15 ml of fluid. You can.